Hello, radiographers. Hope you are doing good. Welcome to a new video tutorial. And this is MR urogram technique. And this is a very interesting and important MRI procedure. So without further ado, let's start. And this is a theoretical lecture video. So at first, the introduction. What is MR urography? MR urography is a non-invasive technique and that uses magnetic resonance imaging to visualize the kidneys, ureters, and bladder, and that is collectively known as the urinary tract. So the main aim is to visualize the kidneys, ureters, and bladder through MRI procedure, and also the flow of the urine, that is urinary tract. And MRI is particularly useful for evaluating urinary tract obstruction, hematuria. Hematuria means blood in the urine, and congenital anomalies, that is the birth defect of the KUB region, especially in patients who should avoid radiation exposure, such as children and pregnant women. That means sometimes children and pregnant women need to assess their kidneys, KUB region, kidney urinary bladder, but due to radiation, CT scan is contraindicated. So in that case, doctors prefer MR urogram because it's a safe and have no radiation hazard, and it's safe for children and pregnant women. And it says that I have told that unlike CT urography, MRU does not involve ionizing radiation and making it a safer option for certain patient population. So I explained it before. And what are the indications for MR urogram or urography? Children and pregnant patients with dilated collecting system. So if this class patients have the dilated collecting system, doctors prefer to choose MR urogram rather CT scan to avoid radiation hazard and to assess the integrity of the urinary tract status post-trauma. So post-traumatic status after any violation or any accident, the patient may injure his kidneys or bladder, and MR urogram can assess this. Suspected or known urethral obstruction. So any urethral obstruction due to stone or due to any stricture or tumor, so MR urogram is best. And then frequent urinary tract infection. Suspected congenital anomalies. So if doctors suspect that this patient have birth defects of kidneys or bladder, that is called congenital anomalies, they advise MR urogram. And urinary tract infections, local staging of cancer. So to evaluate kidney cancer or bladder cancer, genitourinary tract TB, that means urinary tract can be infected by tuberculosis. Urothelial carcinoma, that is a urethral cancer, mainly in female patient. The urethral cancer is common. And urologic malignancy, so that is one type of cancer. And hydronephrosis, so you know the hydronephrosis occurs when ureters are dilated with the urine and obstructed inside the ureter, and the renal pelvis is dilated, and the renal cancers, and the hematuria. So hematuria is when blood comes to the urine. So in this condition, it's called the hematuria. So these are the indications for MR urography. And so let's look at the contraindications. The contraindications are mainly for the MRI machines, and it's are their general contraindication, like patients having any electrical, magnetically, or mechanically activated implant or device like cardiac pacemaker, insulin pump, biostimulator, neurostimulator, cochlear implant, and hearing aids. So these devices are contraindicated for MRI. And then intracranial aneurysm clips, unless made of titanium. And then pregnancy. The pregnant patients have to assess for risk and benefit, and do not use IV contrast in pregnant patients. So MRI urogram sometimes done with IV contrast, but in case of pregnant patient, it should be considered and do not use IV contrast. And then ferromagnetic surgical clips or staples, unless it's made of titanium or any kind of MRI conditional metals. So modern surgical equipments are generally made of MRI compatible metals like titanium, stainless steel, and then cobalt, aluminum. So you have to confirm about this by checking the documents of the surgery. And then metallic foreign body in the eye and metal sharpnel or bullet. So now let's go to patient preparation. For MRI program, a satisfactory preparation is needed. So before, you have to take a written consent from the patient before entering the scanner room, and ask the patient to remove his all metals like keys, coins, wallet, any cards, and jewelry, hearing, and hairpins should be removed. And then for claustrophobic patients, offer a chaperone to accompany patient into the scanner room if possible. So it means that you can provide a patient's relative or staff with the patient to stand beside the machine and support the patient and reassure the patient that there is no problem and no need to afraid, and instruct the patient to hold their breath for the breath hold scans. And it's better to coach the patient 2 or 3 times before starting the scan. So there is protocols for MRI urogram to need that needs to hold the breath, and for this you can train the patient before the scan so that he can understand, and during the scan he cooperate you. And an intravenous line must be placed with extension tubing extending out of the magnetic board. So this intravenous line is for uh, pushing the contrast. It can be a cannula or it can be a catheter attached to the injector. And now another patient preparation, and contrast injection risks and benefit must be explained to the patient before the scan. So gadolinium contrast have some risks and the benefits. So it it should be explained to the patient before the scan. And there may be any allergic reaction, and that is rare. And patient should not drink any fluid at least 6 hours before the scan. And unless fluid signals from stomach and intestines will degrade image quality. So this is important lines. These are important lines that patients should not drink any fluid at least 6 hours before the scan. So patient should not drink any fluid before the scan. And then gadolinium should only be given to the patient if GFR is greater than 30. So if the patient glomerular filtration rate is greater than 30, then patient contrast can be given. And if the GFR is less than 30, that means the patient's kidney is not functioning and contrast should be avoided. and offer headphones for communicating with the patient and ear protection, and properly explain the procedure to the patient. Instruct the patient to keep still. The patient need to keep still uh, to get good quality image, and height, note the weight of the patient, and not the weight only, also height and weight is important to register. And now the patient positioning. So for MR urogram, position the patient in supine position with head pointing toward the magnet, and that is head first supine. You can see on the image, and position the patient over the spine coil. That means that the table itself has the spine coil beneath, and place the body coils over abdomen and pelvis. So you can see that there is two body coils placed over the patient. So if you have two, then it's good, and if you have one, so you can place one body coil over the abdomen, and securely tighten the body coil using straps to prevent respiratory artifacts. And then give a pillow under the head and cushion under the legs for extra comfort. So positioning is very important. Proper positioning gives patients comfort and good quality image. And now center the laser beam localizer over the iliac crest. So over the iliac crest is the mid abdomen region, and register the patient in the scanner as head first supine. So now the methods of MR urogram. So there are two methods or technique for MR urogram. The first one is the static fluid urography, and that is without contrast technique. And static fluid means that the fluid is stacked in one place, like hydronephrosis. In the case of hydronephrosis or the kidney, the urine is stuck and urine is not flowing. So this is the case, and it's called the static fluid urography. And the another one is the expiratory urography, and that is with contrast. And in this technique, we pushed contrast to the patient, and a few minutes later, contrast excretes through the kidney and go down through the ureter, and the images are taken. So let's start with the static fluid urography technique, and this is a without contrast technique, or you can say it a pre-contrast technique. And what is this? Static fluid MR urography is a type of magnetic resonance urography that focuses on the static collection of fluid or urine within the urinary tract. That means that the which fluid or urine is static in the KOB region. So this fluid is visible by this technique, and it relies on heavily T2 weighted sequence, which highlight the long T2 relaxation time of urine and making it appear bright on the images. So if you remind the MRCP protocol, you take a heavily T2 weighted sequence or thick slice T2 weighted sequence in MRCP to visualize only the bile duct and pancreatic duct and gallbladder. So this is the same protocol used for MR urogram. And the pulse sequences for static fluid urography are single shot fast spin echo, single shot turbo spin echo, a half Fourier rapid acquisition, and relaxation enhancement or HAST, trophy, or rare. So let's see some example of static fluid urography in image. So the first image is T2 HAST coronal 3 mm, and in this image you can see that the right renal pelvis is dilated and the ureter is filled with urine, and also you can see the left renal pelvis is dilated and the ureters are dilated. So it can be a case of hydronephrosis, and the bladder is not visible, and you can also see a catheter into the bladder. So next slide is this, and this is T2 Hest coronal thick slice of the same patient. So in this case, this is the 60 millimeter slice thickness, and this is provides us the whole picture of the ureter with kidney and also the bladder. And if you compare with the previous image, that is 3 millimeter, and with this 60 millimeter, you can see that in thick slice you can see the whole ureter in one image. And this is the another T2 has sagittal thick slice image, and it's a 60 millimeter, and it's a right ureter, and it was planned on the coronal right ureter, and you get this. So next move to excretory urography. And excretory MR urography is a type of MRI that uses contrast or gadolinium to enhance the visibility of the urinary tract. So to see the excretion of the ureter or kidney, you have to use gadolinium, but you have to must check the renal function or GFR of the patient before pushing gadolinium, and it's different from static fluid MR urogram. So it's a different technique from static fluid MR urogram, which relies on the natural fluid in the urinary tract. That means that the previous technique, static fluid, depends on the natural urine, but this excretory urography technique relies on the contrast or gadolinium. And then special MRI sequences or T1 weighted are used to visualize the contrast enhanced urine as it moves through the urinary tract. So we know that after contrast administration, we always use T1 weighted sequence, because in T1 weighted sequence, contrast is hyper intense or bright, and you have to also inject diuretics injection like furosemide for the increase the renal function, and it improved the flow and distribution of the contrast, especially in non-dilated system. So sometimes some patients you can find that the urinary system is not dilated in static fluid urography. So when you push diuretic injection, then the flow of the urine increased, and also the contrast flow of the through the ureter is increased, and you can get a good urography image. So let's look at the excretory urography images. So the first image on the left side is the T1 flash Vibe coronal 3D, and it's an arterial phase. So in this image, you can see that the renal cortex is enhanced. So you can see this is a corticomedullary phase. The contrast is collecting through the renal cortex. And the second one is a venous phase, and this is a T1 flash Vibe coronal venous phase, and you can see that the whole kidney is enhanced with the contrast. So it's a nephrographic phase of the urogram. And the third image is after 5 minutes post contrast, and you can see that the contrast gone cleared from the renal cortex, and contrast is now in the collecting system. And also contrast, you can see the left ureter is filled with contrast, and contrast is going to the urinary bladder. So this is the image after 10-minute post-contrast image, and you can see that in this T1 Vibe coronal image that the renal collecting system or renal pelvis is enhanced with the contrast, but ureter is not visible here. And now if you see the 20-minute image, so this 20-minute image gives you a proper MR urogram image with the renal cortex and the both ureter and the urinary bladder. So maybe these images are from the different patients, but you have to take the T1 Vibe headset protocol multiple times to get this image. You do not know when you get the perfect urography image, because contrast continue to flow after 5 minutes, and after 10, 15 or 20 minutes or 30-minute images, one of the sequence can give you this image. So this is a 3D image. So this is a T1 Vibe 3D image. So you can process it on the 3D post processing. So because of the T1 sequence, only the contrast or the gadolinium is visible inside the urinary tract, and the spinal cord and all the fluid is dark. And you can also post process and cut out the unnecessary parts from the UV region. And now let's learn the technique. So first, position the patient in head first supine and place the body coil, we know it, and then administer 25 ml normal saline solution through IV cannula. So administer 250 ml normal saline through the cannula and inject 5 milligram furosemide diuretic injection to increase the flow of the ureter, flow of the contrast or the urine. And you can also use abdominal compression to improve ureteral distension. And the first scan is static fluid urography protocols, that is a highly situated sequence like MRCP, and then give IV contrast if patient's renal function is normal and non-pregnant and no ureteral obstruction. So keep this in mind, and then take excretory urography protocols, and that is a T1 Vibe headset coronal that will give you a urogram image in 3D, and then take arterial phase, that is nephrographic phase, just after the contrast injection, or it may be a corticomedullary phase and venous phase, and this is a nephrographic phase. So I mistake here. If the first one will be corticomedullary phase and the second one will be nephrographic phase, and it is 60 to 70 second post injection, and then excretory phase will appear in 5 to 15 minutes later post contrast. So you have to repeatedly taken this T1 Vibe headset coronal multiple times, and you have to find the proper sequence or proper protocol where you get the full ureter and the bladder. So these are the protocols. The pre-contrast protocols are mainly T1 static fluid technique protocols, and there is axial, coronal, and thick slice images, and also the sagittal right and left images. And coronal, it will be sagittal left, and then coronal a 3D image and trigger image, and then a pre-contrast T1 Vibe headset to compare with the post-contrast images. And these are the excretory phase protocols: T1 Vibe headset, 3 millimeter arterial, venous, and coronal. Coronal delayed 5 millimeter and 10 millimeter. And the protocols are, the first is the localizer, and the localizer will give you, this is a trophy localizer that will give you coronal, axial, and sagittal image for planning the rest of the protocols. And this is the planning for T2 hast set axial, and it will cover the whole KUB region, and it should be planned on the coronal and sagittal image. And then the coronal hast coronal 3 millimeter, and this will be planned on the sagittal and axial image. And you can see that the in sagittal image the plan or positioning block is slightly angled, and it's angled to the or parallel to the ureter or the level of the kidney and the bladder. And also in the axial image the slices should be parallel to the both kidneys. And these are the T2 has thick slice 60 millimeter. So this thick slice images will give you a highly T2-weighted image like the MRCP protocols, and it will give you a full image of the kidneys and ureter and bladder. You can see that the thickness is 60 millimeter, and this is a total a one slice. So this is a one slice, but the thickness is 60 millimeter. A wider slice and should be taken, and the thick slice also would be taken on the both side in sagittal. You can see that this thick slice is planned over the right ureter, including the renal pelvis and the ureter. And you can also see that the planning over the axial image, the angling. So you have to angle like this parallel to the ureter, and this is a thick slice T2 thick slice sagittal, and but in this time this is left side to visualize the left ureter. And you can see that the angle of the slice is in the coronal image. And there is a T2 space 3D trigger 1 millimeter slice. So this is a 3D protocol, and this 3D protocol will give you a 3D image to post process. It is a very helpful protocol to make 3D of the KUB region or urography image. And this is a coronal protocol. So plan on the sagittal image and angle the slice parallel to the long axis of the kidney and urinary bladder. And now a pre-contrast Vibe T1 Vibe fat set transverse that will cover the whole KUB region, and that is 3 millimeter. And there is also a coronal pre-contrast image. You can see the planning of this T1 Vibe fat set. And now I'm sorry, this is a protocol after the contrast is given. This is a post-contrast protocol. So you can get the excretory phase images in this protocol, and it's a 3D protocol. So this protocol T1 bifat set coronal 3D 1 millimeter should be taken after 5-minute post-contrast, and then 10-minute post-contrast, 15-minute post-contrast, and 20-minute post-contrast. So if you didn't get the ureter properly, so you can take this protocol even half an hour post contrast to visualize the ureter properly. And let's discuss some abnormal cases. So this is a 47-year-old woman with right renal calculus. So you can see there is a hypointense signal or dark signal in the renal pelvis. So the T2 weighted static fluid MR urograph confirms presence of filling defect arrowhead. So this is a filling defect because of the renal stone. And this is the case 2. And so in this case, 73-year-old man with impaired renal function, coronal T2 weighted turbo speed echo maximum intensity projection. So that's a MIP image shows with multiple bilateral renal cysts without hydronephrosis, replacing most of the parenchyma. So there is no hydronephrosis seen, but the both kidneys have multiple renal cysts, and the renal parenchyma is almost invisible. And this is a case 3. So let's see what it tells. And this is a case of prostate cancer metastatic to lymph nodes in a 53-year-old man. And coronal static fluid MR urogram shows obstruction of the right distal ureter. So in there, you can see that there is a filling defect here, just at the vesico-ureteric junction of in the right side. So there, this is for the metastatic cancer tumor, and it causes the hydronephrosis, the dilatation of the renal pelvis. And this is the case 4, and you can see that what it says: T2 weighted static fluid urography and T2 space 3D MIP. So this is a static fluid urography, and this is a MIP image showing duplex right renal collecting system and hydronephrosis. So you can see that from the right kidney there is 2 collecting system in the exit and connect here and make 2 ureter. And in this 3D image you can also see this, the 2 collecting system, 2 renal pelvis and 2 ureters forms and goes to the urinary bladder. So this is a duplex renal collecting system. And another case, this is a case 5, and in this case this is a typical case, and T2 weighted image in coronal plane of right kidney with mega ureter. So this is a case of mega ureter and maximum intensity production, that is MIP, and the middle image is the MIP image, right kidney collecting system with mega ureter, and this is a C, this is a 3D volume rendering image. You can see how the ureter is coiling up here, and it looks like a giant snake, but it's not a snake, it's a mega ureter. And in case 6, you can see there is a filling defect in the lower ureter, just close to the vesico-ureteric junction in right side. So what it says: a 55-year-old man with left-sided ureteral stone, coronal maximum intensity projection MIB, exploratory MR urograph shows filling defect in left distal ureter that is causing mild pyeloureterectasis. So this is the condition. You can see that this, because of this the ureteric stone, the ureter is dilated and also the renal pelvis. And this is the case 7. What it tells: a 52-year-old woman with an extensive ureteral obstruction caused by metastatic of an ovarian carcinoma. So this patient is an ovarian carcinoma patient, and for the cancer cell, the ureter is involved and is obstructed, and for this the ureter is dilated and causing a hydronephrosis. So this is case 8, and you can also see hydronephrosis, bilateral hydronephrosis here. So what it says that static fluid MR urography of heavily T2 weighted stick slab with long echo left. So this is the T2 weighted thick slab, balanced steady state gradient echo fista acquisition, so hydronephrosis with dilatation of the pelvic ileal system. So this is a heavily weighted T2 weighted sequence, and it shows the both bilateral hydronephrosis and with the dilatation of the renal pelvises. And also this is a axial image, T2 axial, and it's called the gradient echo or fista. And in Siemens it will be called trophy. So this is case 9. In this case, what you can see, I think the right kidney is missing here. So in this case, you can see that the right kidney is missing. So let's read what is the case. And this is a coronal T2 weighted MR urograph urogram obtained using a thick slab projection technique in a patient who had undergone a right nephrourectomy for transitional cell carcinoma. So that means the patient had right kidney cancer, and for this the kidney had been removed, and it's called the nephrouretectomy. And this is the single 6 centimeter thick T2 weighted MR image shows the left collecting system, ureter and bladder. So 6 centimeter means the 60 millimeter. So 60 millimeter thick slice showing the left renal collecting system and the ureter, and it's in normal position. And this is a case 10 from MR urogram technique. And maybe it's a congenital case, so let's read. An 18-year-old male who had age of 5 years had surgery for congenital left UPJ obstruction. So UPJ means maybe upper upper urinary pelvic junction obstruction. Okay, he was referred for evaluation of the morphology of the left upper tract. After an ultrasound scan showed moderate pelvic atelectasis. MRU was performed with intravenous saline and furosemide using a 3D SPGS sequence. And note the moderate dilatation of the left renal pelvis. So this is the dilatation of the left renal pelvis with no associated calyceal dilatation. So calyces are not dilated, only the renal pelvis, and the cupped non-dilated calyces are better seen on the magnified view, and there is no renal parenchymal loss. So this is a magnified view, and you can see the calyces are okay, but only the renal pelvis is dilated, and this is considered a satisfactory post-operative appearance with no evidence to suggest residual obstruction. So this is the case. So thanks for watching. Hope you like this video. So please hit the like button and don't forget to subscribe my YouTube channel, and obviously hit the bell icon so that you can get the notification as soon as I upload a video. So thank you.